So my name is Alan Higgins. I am the lead for the Health Equity Network, and my colleague Alison will introduce herself.
Hi, everyone. I'm Allison. I am the Health Equity Network coordinator, and this is my last Health Equity Network webinar. I'm going to be leaving the 6th of December, so this is my last webinar for now.
I think everybody needs to know Alison's joining us from Boston this morning, where it's, what, 7:30 in the morning, so an extra effort to attend. So this is the Health Equity Network, one of our monthly webinars, this time on disability, employment and health, which we're delighted to have a number of speakers lined up for this very important subject. And the way that we run these, if you've not been on them before, is that we have speakers generally for about 25-30 minutes. And then we open it up to the audience, the participants, for questions, for comments as well. And we will conclude by 1:30, because we know we're all busy and it's lunchtime and you deserve a break as well. So we will make sure we finish by that time. We also try to keep this fairly informal. So as I said earlier, if you are able to turn your cameras on, then it's always nice to see people. If you can't do that, that's absolutely fine as well. It just makes it slightly more easy to communicate when you've got some faces in front of you. So please do that if you can do. And if you can stay on mute when you're not speaking, then it makes sure that we don't have any background noise coming in. And you'll have an opportunity to speak later on by raising your hand, using that hand facility on Teams as well. We do like to record the webinars, because it then means that we can edit them, Alison can edit them, and we can put them up on the Health Equity Network site as well for people to refer to. So I think that's all the housekeeping that I needed to cover. So disability, employment and health. We have great speakers lined up today. It's an opportunity to find out about current inequality and access to employment for disabled people. And we'll have Dan White from Disability Rights UK kicking us off in a minute. And then we've got Emma Cameron and Ellie Thorne from University College London Hospitals talking about the service that they provide there. And then delighted that we've also got Pippa Sargent and John Dobson from the Brain Charity, also talking about services provided, particularly in the Northwest. And then after that, we will open it up for questions. So we'll have all the speakers, and then we'll open up for questions. Somebody who isn't on that agenda, but has been instrumental in setting this up, is Ruth Austin Vincent. Giveaway of Ruth, who is the Stakeholder Engagement Officer at Multiple Sclerosis Society and has been so instrumental in working with myself and Alison in getting speakers lined up for this. So it's right that we give Ruth some acknowledgement there too. So if we're all good to go, then I'll hand over to Dan, who is in a Costa somewhere. And Dan, are you able to come on and start your input?
Yeah, absolutely. Can everyone hear me?
We can hear you, can't quite see you, but there you are.
Brilliant. Okay, what I'll do is I'm going to turn my camera off because the Wi-Fi is a bit patchy, so that's okay. So hopefully give it a bit of a boost. But yeah. Thank you, everyone. I'm Dan White, Policy and Campaigns Officer from Disability Rights UK. I live with a hidden disability and I'm a carer for my disabled daughter, Emily. And I've just literally brought employment under my wing as a policy area. So thank you for having me. But it's no irony that this year's theme for UK Disability History Month, which runs from the 14th of November to the 20th of December, is disability, employment and livelihood. It is also timely that this talk comes a day after the launch of Labour's Get Britain Working white paper, which includes much potential policy around getting disabled people into work. However, the premise of this Disability History Month is to raise awareness of issues, including the underemployment of disabled people, which has created a significant disability employment gap. While many factors contribute to the disability employment gap, a key area of research has been the barriers to finding and starting work for disabled people. According to research for Disability Rights UK, businesses lack confidence hiring disabled people, fail to understand how to make adjustments, and struggle navigating systems such as access to work. While at the same time, disabled people describe demoralizing job searches, sometimes applying for hundreds of jobs and difficulty identifying inclusive employers. While the contribution disabled people make in the workplace is increasingly valued by UK employers, the disability employment gap remains stubbornly high. Increasing the number of disabled people in employment has wide-reaching benefits for businesses, disabled individuals, and of course the economy. But according to research, as few as 13% of businesses think they are doing enough to increase the number of disabled people they employ. These concerns are shared, of course, by disabled people across the country who report experiencing long job hunts, negative attitudes, and indeed outright ableist practice, sadly, when looking for employment. So what is stopping businesses in the UK from hiring more disabled people? And why are so many disabled people facing such a difficult time getting into and staying in paid work? Well, firstly, disabled people make up a significant part of the working age population. In the UK, a third of adults aged 16 to 64 are disabled, neurodiverse, or have a long-term health condition. This number grew significantly, unsurprisingly, of course, during the pandemic, with the rise in mental health crisis and, of course, the effects of long COVID upon people. Indeed, over the past decade, the health of the UK's working age population has incredibly sadly deteriorated. According to the Health Foundation, more than 8 million people, or 20% of those aged 16 to 64 years, now have health conditions that restrict the type of work or the amount of work they can do. Disabled employers in the UK are subject to a further disadvantage through a significant disability pay gap. In 2020, the Trade Union Council reported disabled people earn on average £2.10 less an hour than non-disabled workers. And this year, the disability pay gap reached a staggering level. According to new data released by the TUC, the pay gap has now widened to 17.2%, meaning non-disabled employees earn on average £2.35 an hour more than their fellow disabled workers. Other research shows the reasons behind this. It shows the types of adjustments that employees with disabilities and progressive conditions value most, such as reducing the level of responsibilities of their role or even job sharing, will inevitably widen the disability pay gap. We must also remember that for any potential disabled employee, that they've often faced additional expenses, including high gas and electricity bills, home adaptation, sensory equipment, mobility aids, and specialist food bills. Analysis by fellow charity Scope only a couple of months ago found that non-disabled people must spend on average an extra £1,010 a month to maintain the same standard of living as non-disabled individuals. So as well as an incredibly unfair and demoralising pay gap, other multifaceted issues of disability employment are there. Education in early years is one such prime issue. A report released only last week highlighted several challenges working age disabled adults face in their daily lives across health, education, and especially employment. It showed disabled adults are twice as likely to leave education with no qualifications compared to those without a disability. And just 5% of adults with a learning disability are known to the local authority are in paid employment. This, of course, proves succinctly the fact that the failing and cash-strapped SEN education policy robs disabled children and young adults of the tools needed to seek employment of their dreams as they leave the school environment and enter the possible working world. Moving on from education and not having the skills or indeed the confidence to enter the labour market means, of course, needing to claim benefits. Disabled people who want to work but remain on benefits often feel trapped. There is a real sense of insecurity and risk of losing benefits or being made otherwise worse off because of engaging with a DWP or moving into work. Almost 3/4 of work-related disability benefit recipients surveyed by the Joseph Rowntree Foundation said that fear of losing benefits was a significant or very significant barrier to work. And of course, it doesn't help that benefits in the UK remain amongst the lowest in Europe. These fears have three key aspects: fear of trying work or engaging with employment support leading to benefit reassessments, loss of personal independent payment, PIP, or extra support and universal credit, increased conditions, or of course, the risk of further sanctions. Insecurity about trying work, but then not being able to fall back on the same safety net with the same conditions should the job not work out. concern that wages may not be enough to offset the withdrawal of benefits or the overall financial gain not being enough to outweigh the considerable risks. The system from the outset, especially the DWP, with its sad history of brutalness and indifference, creates an atmosphere of fear for disabled people who soon feel trapped within it. Radical change is urgently needed. And thankfully, much is proposed, like I said, with this new white paper that was released this week. But we saw under the previous government that when they published the National Disability Strategy, it revealed that the then government intended to reach its goal of helping 1 million more disabled people back into work. But all this was done without working with disabled people, in their words, to think about how we can build on this success. Recently, ourselves at Disability Rights UK wrote to Alison McGovern, the Minister for Employment, regarding the lack of disabled voices in the new Labour Market Advisory Board. The work of the board is obviously important, as it inputted into the white paper on supporting people into work released on Tuesday. Our letter to government made it clear that when the lives of disabled people are being discussed, disabled people must be at the heart of engagement, as we have the expertise and lived experience to know what works. And it was a slight win to read in the paper regarding employment policy that, to quote, there will also be a disability panel set up to ensure the voices of disabled people are at the core of reforms. So we wait and see. So if employment for disabled people is to be transitionally easy, if governments and employers are honest about getting more disabled people into work, then policies and dialogue with the community is imperative. So we hope we are contacted and our voices are listened to and acted upon. But as I said, these are just a few of the multifaceted issues of disability employment. There are many, many more than 10 minutes can cover. So what are the responses? What are the answers? The white paper speaks of governmental ideas of what policy will work, but here at DRUK, we have worked and are working on policy which we've implemented and discussed could go a long way to some resolution and cooperation. For instance, I'll give you a few. Employment and pay gap reporting. The government should require all employers with 250 plus employees to publish data annually on the number of disabled people they employ as a proportion of the workforce, their disability pay gap, and the percentage of disabled employees with each pay quarter, supporting disabled people into employment. The government should increase disabled people's access to employment programs and apprenticeships, increase the scale, quality, and awareness of supported employment programs and supported internships, and increase the provision of tailored careers advice to disabled people. We need a reform of the Access to Work scheme. We need reform of Disability Confident, which is a scheme run by the government that encourages employers to think different about disability and to take action to improve how they recruit, retain, and develop disabled staff members. The government should require all employers at disability confident levels 2 and 3 to meet minimum thresholds regarding the percentage of disabled people in the workforce. The government should also ensure award decisions for all public sector contracts take into account the percentage of disabled people in the workforce of tendering organisations, require government contractors to work towards a minimum threshold regarding the percentage of disabled people in their workforce. There should be more done on workplace adjustments. There should be more working with disabled people and their representatives. And of course, there should be more advice and support. The government should create a one-stop shop portal to provide information, advice, and guidance to employers on recruiting and retaining disabled people, and to disabled people on their employment rights. Without policy and action like this, without collaboration, nothing will change. The onus on getting disabled people into employment should not just be on the disabled individual themselves. The responsibility lies further with education, lies with the inadequate and cruel benefit system, it lies with government stereotypes, and it lies firmly at the door of the employer. Many disabled people do want to work, so let's empower them to do it from school onwards. Thank you very much for listening.
That's brilliant, Dan. Thank you so much for setting that context and setting it so powerfully as well. I learned such a lot actually from what you've just been talking about. So thanks very much, Dan. And you'll be on the call for the rest of the webinar too. You know, please do come back in again. But excellent, really, really powerful beginning to the webinar. Thank you. So I'll come next to Ellie and Emma from University College
Hi, yes.
London.
Can you hear me okay? Oh,
I can hear
Yeah.
you. Yeah, that's
Perfect.
great. Please do introduce yourselves again and then move on with your presentation. Thank you.
lovely, thank you. So I'm Ellie, I'm the highly specialist occupational therapist, and today joining me is Dr. Emma Cameron, the clinical neuropsychologist on our team. And today we're going to be discussing an overview of our vocational rehabilitation service at the National Hospital for Neurology and Neurosurgery. So today we're going to discuss what is vocational rehabilitation, why is it important, our service, the intervention streams, a case study, and our contact details. So what is vocational rehabilitation? So vocational rehabilitation is whatever helps someone with a health problem to stay at, return to, or remain in work. It's a process which enables persons with physical, cognitive, and psychological impairments or health conditions to overcome obstacles to access, maintaining, or returning to employment or other useful occupation. It's supporting someone to have a good exit from the workplace. So why is it important? So disabled individuals find it harder to return to or maintain employment. So 24% of the working population is disabled. There's a lack of work associated with decreased physical and mental wellness. And the longer people are off sick, the less likely they are to make a successful return to work. So recent studies suggested if you take more than 6 month absence, only 50% chance of a successful return. And ill health costs the economy. So it's been estimated it costs the economy approximately 100 billion a year. So increased uses of services such as this helps with the government as well. So it is good for the individuals we work with, ensures workplace productivity, wider societal benefits of economic success, and converting benefit recipients into taxpayers. VOC Rehab is the process whereby we can help our patients achieve this with early intervention and an open access, responsive and personalised service. So we work within a multidisciplinary model, with the service being comprised of neuropsychology, OT, and consultant neurologists. So we're a tertiary service that has been running for over 10 years. We aim to provide more complex and long-term interventions that are not available in people's local areas. We generally receive referrals from people living in London and the surrounding areas, though we do accept referrals from across England if appropriate. So this depends on the patient's local provision. But just a quick rundown, you can see we've got a consultant neurologist, 2 Band 8 highly specialist clinical psychologists, Band 8 OT, 2 7 OTs, and assistant psychologist. So we see any neurological conditions for people aged over 16 and above. So this could be single incident conditions such as stroke, traumatic brain injury, and spinal cord injury, and long-term conditions such as multiple sclerosis, epilepsy, and neuromuscular diseases. So patients we see have a job or study to return to and must be ready to be actively engaged in VOC Rehab. We are not able to provide support for job seeking or where the primary difficulty does not relate to a neurological condition. So this is our patient presentation from 2024. So you can see majority is stroke and MS, but a wide range of conditions as well. Patients often have comorbidities, so other health conditions like cardiac issues, respiratory issues, and mental health conditions. So just breaking that down for the larger ones, it was 102 strokes, 63 MS, and tumour, neuro-oncology, neuromuscular, and 15 TBI, 8 FND, 4 Parkinson's, 4 epilepsy. So we support patients to return to their job or study after a period of sickness, or work maintenance for those in work. So example, if there's a relapse or change in progressive condition, or could be a change to the job role, manager, etc. We support with adjustments in education and new roles, and key successful work exit as well. So that might be people looking for ill health or medical health retirement. So we support at key work workplace transition points. And these might be initial employment, examinations at diagnosis, time off with sickness or relapse, job changes due to job loss, manager change, progressive difficulties, and as I said, considering ill health retirement. We may work alongside occupational health services or private rehab services, although these are not available to all employers and may not offer the same level of skills and support that we can. So I'm going to talk about the barriers to work and study. So that's the nature and severity of the neurological impairment, the skills and demands of the job role, the work culture, the type of industry, the employer's attitudes to disability, comorbid presentations, and psychosocial factors. So Emma's going to take over now for discussing the interventions.
Hi there, everyone. Hope you can hear me okay. So the type of intervention that we offer patients really depends on the individual factors and barriers that Ellie was just mentioning. So just a little bit of what we can do is our neurologists might review medical symptoms if that's impacting on patients' work. So if they're getting headaches or dizziness, so they might pull up sort of MRI scans or kind of request further input from a neurologist. We can help patients understand changes to their symptoms, and we use the word patients because we're part of a hospital setting, but I understand other people might use different terms. But changes to our symptoms, so we might look at doing a neuropsychological assessment, so that's a test of our thinking skills to get kind of the breadth of strengths and difficulties that someone's experiencing with, for example, memory or planning and other things that might be impacting on that, like fatigue or mood. And then introducing some strategies to enable them to just manage those in the context of their work, and obviously applies to their broader life, but we're a vocational rehab service, we've got to focus on that remit. But you know, if someone is struggling to cope in a noisy kind of open plan office because of attentional concerns, then we'd use the assessment and the information that the patient's giving us to kind of think through what strategies would best help them and what reasonable adjustments might help in that setting as well. We can support with managing difficult emotions as well, associated with adjusting to the condition in the context of their work, the impact on their sense of identity and kind of work relationships. We can do that as an individual or group setting. So we don't do general adjustment to diagnosis work because, again, we've got to focus, unfortunately, on just the VOC rehab setting, but adjustment in the context of work in terms of perhaps changes to their job role that feels quite emotionally difficult for them, or sense of identity in terms of perhaps if they're having to exit work and that was a large part of their life, and, you know, who am I now, and, you know, what purpose do I have, or changes to work relationships because of lack of understanding from colleagues or the employer, or just anxiety about managing communication in that setting. So lots of different things. We also do fatigue management. That's mainly OT led, very specialist at that, and that can be in an individual or group setting. So helping them understand what is fatigue, what are the triggers for it, kind of picking it apart to see what exactly is going on, what kind of energy levels people have at different times, so kind of that boom and bust that we sometimes see, to try and help people manage their fatigue more effectively throughout the day with useful strategies. We can also do workplace assessments to see if we can kind of tweak the setup and kind of help people, you know, in the workplace a bit more. We also do a lot of signposting to IAPT for mood and wellbeing, I should say, outside of the scope of VOC rehab. We also assess readiness for a return to work. We tend to do that by supporting people to establish what we call a kind of work hardening program as part of their return to work plan. So what that means is that whilst someone's at home and they're not in the work setting, we try and simulate the type of tasks that they might be doing at work at home, so they can practice them in a safe environment and think about any problems that are occurring, any strategies they need to use in practice, and build that up in a graded way so that they're ready to return to work at that point. They've got the routine in place, they've been practicing the skills, and they might not be able to practice the exact job tasks because we see, you know, a whole wide range of people. You know, for example, if you're a laboratory assistant, we don't have all those equipment, but maybe we're looking at using fine motor skills because they're tweezering different things, or there's different skills we can practice without actually having the actual task. So we're trying to simulate the skills and the task if possible, but at least the cognitive or kind of motor skills that person would be using to see, can they do these things, what are the barriers, and how can we help make that easier, and can we build up the tolerance to doing that routine over time so that they can do, for example, perhaps 3 hours 3 times a week to be able to then meaningfully return to work, because perhaps less than that is, if you're just going in for an hour and you're just checking emails, you're not going to meaningfully contribute. You need to be able to tolerate a certain amount of time. So we can do a functional analysis of specific work tasks. So that means doing a face-to-face assessment of some tasks so that equipment or strategies can be recommended. So there's a patient I can think of who did an aspect of gardening in his role, who came in and was assessed actually doing some gardening on site, and that was really helpful. We can assess and evaluate the job demands, so reasonable adjustments can be identified, and that can be a whole wide range of things. So from thinking about hybrid working or more working from home to sort of smaller things like having Dragon Dictate, like speech to text software, to help it, a whole wide range. And we help plan that graded return to work with the adjustments, and we can communicate that to the employers in letters and meetings. And we can also give letters to support ill health or medical retirement, and kind of in support of that based on what we've seen. And we do refer on to other services as well, to kind of maximise rehab and signpost to kind of relevant work support agencies like work coaches at the job centre, or if there's a more of a mental health remit, then perhaps Maximus, which is part of Access to Work, could help. And we would signpost to services for people who might be job seeking, because unfortunately, as Ellie said, that's not within our remit. And just aware of the time, are we going to 1 o'clock for me? Is that right? I didn't want to go on too long. Yeah. So we've got a bit of a case study here, so I won't go through it too much, but everyone's more than welcome to have the slides. And it was just an example of a primary school teacher and some symptoms that she might be experiencing post-stroke. If we go on to the next slide, this is the sort of information we might try and get from people about their work situation and particular worries that they've got, so that we can really think holistically around the issues to come up with intervention and adjustment plan, which is the last slide I'll talk through. Reflections on, so GRTW, that's graded return to work, and that's just an example of some of the things that we might do that I'll just let people sort of look through in their own time, just due to time limits. But our contact details on the last slide, if anyone did want to get in contact, if there was someone that they thought would be useful for our service to support with, more than happy to take queries, and that's just how we accept our actual referrals as well. So thank you very much.
Excellent. That's fantastic. Thank you very much, Emma and Ellie. Did you want to come in again, Ellie? No, that was it. That's fantastic. I'm struck every time I hear a presentation like this about the kind of centrality of occupational therapy to so many conditions, and it's, at least in my perception, an undervalued service. So excellent to hear about that service. And there are people who are wanting to connect. There's been some questions coming through on the chat. What I'll do is move on to the next presentation in a moment, and then come back to those questions and invite people to come on screen to ask those. It's also great to see people making connections through the chat function. Please do keep doing that. That's what the network is here for. So without spending much more time, I'll move on to Pippa Sargent and John Dobson from the Brain Charity to come on and talk us through their presentation and skills and slides. Very much looking forward to this too. So Pippa and John, take it away.
Hello. Hi everybody, I'm Pippa Sargent, CEO at the Brain Charity. My pronouns are she, her, and I have a hidden disability.
Hi there, I'm John Dobson. I'm the head of projects and services at the Brain Charity, he, him pronouns, and we're here to talk to you today a bit about what we do at the Brain Charity.
So I'm just going to spin through really quickly to keep time about the Brain Charity, because you might not know who we are. So we're the only charity in the UK providing specialist support for every single neurological condition. So we offer practical help, emotional support and social activities to people who experience a neurological condition, or their families and friends and carers too. We are a one-stop shop for that expert advice in the community, and that expert advice includes lived experience. And we were born out of a major trauma neurological centre, the Walton Centre in the Northwest. So there are more than 600 neurological conditions. Emma and Ellie went through some of those earlier, so I won't go over that. And they affect 1 in 6 of us. So 1 in 6 of us is a lot of people in every room that you're in every meeting that you're in, including this one. And it's often more than people think. We know that services and rehabilitation can be really patchy. It can be a bit of a postcode lottery, and waiting lists are really long. Stigma and misunderstanding of neuro conditions like mental health and others is a big cause of hardship and isolation. So we're in the community to support people in that situation alongside the NHS and other health providers. The last one for me now, just to let you know, we are based in Liverpool locally, but we have a national reach. So we do a lot of our services online or on the telephone, and training as well. We go out individually to different places. This is the kind of stuff that we might support. So benefits, advice, housing queries, and obviously work and employment is in there. We also have a neuro gym on site, so we have physios and OTs working with us to support people with specific conditions. We champion neurodiversity, so we provide training and support for businesses and organisations to become more neurodiversity friendly. So we provide support through employment for people who live with disabilities, but we also provide support for employers as to how to become more neurodiversity friendly at both ends of the scale. I'm going to hand over to John now.
Fantastic. And so we've been invited here to speak to you all about what we're doing to support our clients kind of in this area of employment. And that can be as part of our information and advice service to provide some guidance to people about what is out there for them. We heard from Dan earlier, didn't we, about all the different ways in which there can be barriers for people. And some of that barriers on an individual basis can be just the person with a neurological condition not understanding the kinds of support that they could be asking for, the sorts of things that are their legal entitlements, the kinds of employers, the things that they should be doing. So we support people who make inquiries to us with information about how to approach their employer, how to ask for what they need, the kinds of things that Emma and Ellie shared about, the sorts of things we can support with, and likewise understanding the Access to Work scheme, what it is that kind of by way of equipment and extra adaptations can be put into the workplace by their employer through that funding stream, so that the person themselves as the employee can get the best support they can to ensure that they stay in the role they have. In whatever it is they're doing. So that's a key part of what we do for people who are currently in employment. But then the other aspects of what we deliver is a real community-led project for people in our community who need some support with personal progression with those skills. We've heard before about kind of all the barriers that can really hinder people from starting out this journey to trying to find out what the next step is for them. There can be a lot of fear around that. So we have our project that we are running in the Liverpool City region called the Value of You project. We're currently working with people who are in that economically inactive bracket that we hear quite often on the news. And this project we have is currently funded by what has been the UK Shared Prosperity Funding in partnership with other local community organisations, so that people can come to a charity for some support to understand kind of what could be next for them kind of on an employability basis. We call it the Value of You project because it's all about promoting each individual's positive sense of self-worth and personal growth to help them see their potential ways of progressing with their goals in life. Because as we've heard, some people kind of getting into work can feel out of reach. So really the core of our programme is focused on confidence building, acknowledging people's strengths to form that foundation for whatever next steps of progression they feel they want to do, whether that is volunteering to learn some skills, whether that's engaging in training towards an area of interest, or any of those things that can be part of it. And people can arrive with a lot of fears around financial security when showing a desire to move closer towards the labour market. So we don't often position for many clients this support as being a push towards employment. It's more about reducing that pressure to help people feel they can grow personally, to see what next steps they can take. And a key area of that project delivery is our confidence coaching group workshops and one-to-one sessions for people living with neurological conditions. In these sessions, people can explore kind of a growth mindset, raising their awareness of traps of self-doubt, identifying strengths and stepping outside of their comfort zone, so that they can have a place to consider and reflect on how they can step into their goals and the next steps for them. It provides them a place to reflect. There are tasks for them to complete between the sessions in that supportive environment, and then they can consolidate those learnings about confidence with working with our key workers, who then put that into practice with them, and kind of on an employment coaching basis, producing action plan to see, you know, what it is that they can move on to closer towards employment. And we've had a lot of really positive feedback from that approach, of that foundational building of somebody's confidence to get out into the workplace or into some training or developing themselves. We've had people who've told us, you know, we've got things on the slides of what people have passed on as their feedback. People feel more able to advocate for themselves. It gives them the skills they're going to need if they can get into the workplace to demonstrate how much of an asset they'll be, and how, whilst also being confident, to be able to ask for what they need in return, to be able to support them to thrive in work whilst they're living with their neurological condition. And we've heard about so many ways in which that there can be those barriers put in place for people that's outside of their own control. And I guess, you know, it'll probably come up in the discussions as we come to it, all the ways in which interventions such as this can be beneficial for an individual, but it doesn't necessarily change the environment that they're trying to operate in. But with that intensive support and the care and attention they can receive from our teams to support them through each step that they need to get to that point of stepping out and trying to find something suitable for them, we've found real benefits to those who've engaged with us. And so, as I've said, that's the support we provide kind of for the individual on behalf of them as employees or prospective employees. And I'll pass back to Pippa, who'll tell us a bit more about how the offer that we have for people who are employers themselves.
Yeah, thanks, John. So we offer neurodiversity in the workplace training here. We've been running for over 2 years, so we're quite well established in terms of what we offer to a wide range of organisations. We do support small organisations, but also really big ones as well, like we've trained BMA, Kraft Heinz, some NHS trusts and some departments of Health Education England. So what we do is we work with a team of neurodivergent trainers across the country to go in face-to-face or online to provide a bespoke training package. It could be in 1 hour, it could be a half-day session, it could be more, it could be working with managers around policy development. We cover things like recruitment and the policy development, adaptations for workplaces, supporting neurodivergent staff specifically, and kind of understanding those reasonable adjustments that we can put in place as employers, and really much more. I think the really important thing that we try to get across to the people that we work with and the employers that we work with is that some of these things that we're saying need to be put in to support people with neurodivergent conditions are good for everybody. So the flexible working, perhaps thinking about our light situation in a room or the noisiness. We allowed everybody here in the Brain Charity to wear headphones whenever they want, if that suits them. And we have 50% neurodivergent staff here at the Brain Charity. So, you know, what we try and look at is that strengths-based approach. So what is it that neurodivergent people can bring to your organisation specifically, and pulling that out, because we should, again, do that for all staff to get the most benefits that we can. Obviously, in terms of working with business, there's a potential productivity advantage to this, but at the Brain Charity, we'll only work with people who are really committed to the culture change that they need within the organisation to support these kinds of measures. And, you know, many of the solutions are really cheap or free to implement. The flexible working, for example, is really easy to do, and the software which we can provide to people, it's about increasing understanding and kind of changing thinking within the workplace, really. So it's just a snapshot. Please have a look at the website if you want to find out more. There's loads of resources on there as well. Thank you.
Thank you very much.
Another brilliant presentation. Thank you so much, John and Pippa. It's so good to hear about that work and that aspect of it to do with working with employers. I think I was aware of it. I didn't realise, I didn't appreciate quite how much goes into that work. So it's great to hear about that. And there were comments in the chat that kind of recognised the value of that work. Great point as well about may be driven by meeting the needs of people with neurodivergence, but also will be good for other people in the workplace too. So excellent. So thank you very much for that. So what we're going to do now, and up until 1:30, is just open up for questions about anything that Dan brought up right at the beginning, anything that Emma and Ellie brought up too to do with their service, but then also to do with John and Pippa's presentation at the end. So I'm going to hand it over in a minute, but I'm going to go first of all because there were a couple of people flagged up questions in the chat. Grace, would you like to come on screen and just go over that question that you highlighted earlier?
Yeah, sure. So is my camera working? Yeah, sure. Hi, thanks to all the speakers. I've learned so much today. Really insightful stuff. My question was for Ellie and Emma. I'm really interested in sharing various different models of good practice across the English regions. My key stakeholders are the mayoral regions such as Liverpool City region, which John and Pippa work with. But given the recent mandate to the NHS within the Get Britain Working White Paper to essentially be doing more to support employment outcomes, I'm interested to know whether the model that you have at UCL, whether there are other similar services across the country, if that's known, and also really interested to understand where that mandate came to set up your service. Where the funding comes from, how that's been sustained over 10 years. I can imagine that's been really challenging. So if you had any insight on any of those aspects, I'd be really keen to hear about that.
Thank you. Hopefully we can answer some of it. I'm not quite sure we've got full insight into all of that because neither of us were here at the service set up. But it was set up in 2013, and because we're integrated in a neurology specific hospital with lots of kind of general rehab going on, and it was flagged up that there was this specific work intervention that was an unmet need and taking away from resources of general rehab, but specifically the focus initially was more on multiple sclerosis, on MS. So it was set up in 2013, and at that point and for many years it was one of only 2 kind of consultant led specialist VOC rehab services. Well, it's still in London. And I mean, going outside of London, because I can see you said you were interested to know services across the country. I mean, I don't think Ellie or I would know fully the map of that, although we have got a working party from a local group that is trying to map that out. It is very patchy. It's a bit of a postcode lottery. There's definitely pockets in the country where they don't have provision because we see patients from those areas, so we know there's nothing locally. I think London and surrounding boroughs are quite lucky in that regard. And in terms of its commissioning, I mean, it's NHS commissioning as a standard outpatient service through the hospital. It has, I think, been a battle to increase the staffing provision over the years, but actually maintaining the service has not been an issue. It's been about trying to balance the supply and demand, because we do get an awful lot of referrals and unfortunately long waiting lists that come with that, and actually trying to get more staffing established. As you know, we've recently got that this year, which has been lovely, but that's been the main kind of battle for us, is actually expanding the service. And initially we did offer support with job seeking, but we had to cease that just because of the amount of referrals coming in and the limited capacity of the staff team and kind of our own well-being. So yeah, it's fluctuated a bit over time. You know, we moved away from just MS as well and widened that up, but yeah, I hope that helps a bit.
Thanks very much. Go ahead, Grace, if you want to come back.
Oh, sorry, I was just going to say thank you. Really insightful. Oh, if I could be connected with the colleague who's mapping the services, if that's able to be shared, I would really appreciate that.
Excellent. Either follow it up afterwards or through the chat, whichever suits you best, Emma. Great, thank you very much. I'll go to Owen, who posted a question earlier, and then we'll come to Jan. Owen. Are you able to come on, Owen? While Owen's perhaps finding the mute button or the off mute, the question was to do with referrals into your service, Emma and Ellie, and it wasn't many more specific about than that, but could you maybe talk about where you get referrals from?
I guess, so we do get referrals from all over the place, so all over the UK. So because we are a virtual service, but we do face-to-face clinics as well, but most of our service is virtual, so on the MS Teams platform. On the slides, which I think will get sent around, it is via GP, the e-referral system. So patients go via the GP, but if there's any questions about appropriate referrals, we also have our contact email detail on that if people get in touch.
And if people have a consultant who's involved in their care as well, so say they have a local MS consultant or something like that, consultant neurologist, then they can also refer into us. And I can see Owen's question was, can an organisation refer to your service? I mean, I don't know what type of organisation Owen was thinking of, but they can always pop an email in and inquire, and we can kind of think about it as a team, and our consultant neurologist can get back to them. Yeah.
Excellent. Thank you very much. Thanks for the question to Owen. Jan, you'd like to come on and put your point.
Hi, everyone. I'm a brain injury mum, and I put a little note in the chat about Matrix Neurological, which is the charity I founded just over 10 years ago, after I had to rehabilitate my own son following his severe brain injury. The Tees Valley is and the whole of the Northeast, in fact, is very poorly served by any neuro rehab support services. So based on the lack of knowledge and lack of understanding amongst a range of community professionals, I founded Matrix Neurological to initially provide peer support for families, for parents and carers, to help them navigate through the nightmare. But over time, after hearing how well my son had done, his prognosis was he's going to have no quality of life because the damage to his brain is so extensive, 2 degrees later, he's now working and employed, and everything they said he wouldn't be able to do, he now can. And that is because as parents, we didn't give up. So other parents have then been saying, well, I want for my child what you gave to yours. So we, for the last 7 years, with funding from BBC Children in Need, have been delivering non-clinical interventions aimed at addressing physical problems they're left with, sensory problems, cognitive issues, communication issues. We've been sent an aphasia program from a university in America. So we've gathered our resources from lots of different places, and I suppose we as parents are so sick of people failing our children and mental health services receiving no training in brain injury, trying to treat conditions that they don't understand and actually are harming children, that we've now decided we'll just do it ourselves, because the NHS has been failing these families for the last 30 odd years. So that's kind of where we're at. But what I wanted to feed in for Ellie and Emma is just some feedback from our kids, which might help your, I don't know, I'm not saying your service isn't running well, I'm sure it is, but it's just feedback that came from our kids. What they have told us is that strategies don't work. And for every child that was given a strategy to use at school, they have left school just as disabled as they were when they first went back to school. Nothing has improved, and strategies may have gotten them through school, but haven't helped them with any part of their neuro rehab, which then means they can't move into employment. So that's an issue. So we work a lot on cognitive function. Our approach is actually very similar to yours in terms of gathering the medical information, looking through past performance, looking at how they're performing now. But so that's an important piece that has driven a new project that I can't say anything about, but we've just been awarded a substantial amount of money to do something quite innovative for children and young people with acquired brain injuries. But the other thing that the kids have told us is quite often rehab work can be quite clinical and the kids hate it. And when we've looked at clinical resources, the kids are saying it's boring, it's difficult
Jana,
to
I'm just
engage
going to
with.
ask you to round up so we can get a response to your points. But anything
Okay,
final you
yeah,
want
it's just feeding those things in that children like. For clinical professionals, it's important that you understand the learning needs of children as well, and
Okay.
what they're like, and changing language, and because a lot
that's
of
great, Jan.
standard things.
Let's stop there and just get a response. I'm going to invite John and Pippa just to respond first. That's a fantastic story, not just about your son, but just about the success you've had in setting that up. Pippa and John, would you like to? Does that chime with your experience in the charity
I think it really shows kind of the role and the benefit of these community-led initiatives, and I guess the responsiveness of organisations like Jan and ours to be able to hear what's required of the people that we're serving and try and adapt what we're doing to help support them through challenges within services that are there and all those sorts of things. So yeah, really hear your points there, Jan. Thanks for sharing.
Yeah, excellent. Emma and Ellie, there were some specific points there. Would you like to respond to those that Jan made?
Yeah, I guess it's very difficult not knowing the personal experience in the service that your children were accessing. I mean, our service is 16 plus, so obviously we do support children, but only at the latter end of their childhood experience. So possibly not quite the point at which you were talking about, but certainly we do try and individualize the experience for each patient and use the language that's most appropriate for them. And it just sounds like you're setting up something really valuable. So yeah.
Thank you.
Excellent. Yes, great points, Jan. So we're nearly out of time, but there is time if anyone would like to come in with a question. And I'm going to keep talking, but just put your hand up or just come in, please. So I'm go ahead. Here's that then. Sorry, it just comes up as SW, but Shauna. No, Sarah. Please
Hi,
do.
yes, sorry, Alex. It was just to say to Jan, I have put in the chat a contact for After Matters. It was a mum who came to speak to our community of practice vocational rehab group in Greater Manchester. She shared the exact same experience of you that you've had with a son who had an acquired or a traumatic brain injury, I think. She linked up with another mum on the ward who was in the same position. They felt that there was a lack of provision for their boys, and so they've set up this charity After Matters. So although she's not in your geographical area, it sounds like you've got a very similar experience and very similar sort of situation, and maybe it's worth linking up with them to peer support each other and to ensure that both your charities are covering the needs that are being identified. Thanks.
Excellent. Thanks so much for that contribution. And it just brings me to the point as well that through the Health Equity Network, as Alison posted earlier, there is a group now set up through which people can carry on this conversation. They can do it across the whole network, of course, but that one will specifically be looking at disability employment and health. And people are very welcome to join that group, but then also to take a lead in setting the agenda through that group. And that's how the network functions. We won't be attempting to run it for you. Thanks for putting that up again, Alison. Please do join that group. Any further questions or points that people want to just reading through your point, Julie, but anyone else who would like to come on, please do so with a couple of minutes remaining. I'd also just say that the comments that we've received in response to the questions, in response to the presentations, have been overwhelmingly positive and grateful for the presentations. Helen.
Thanks, Helen. Just wanted to give a shout out to the Lilac review. I've not done a lot of involvement with it, but I know it's going on. So those that can go and access that, especially for self-employed disabled people or people with disabilities. And then I think also a little bit of a shout out for the stigma of it all and the parity of esteem between different differences. I think that, you know, that I don't know what point I was trying to make. Maybe I'll just stop at the Lilac review. But yeah, I think, you know, when we're designing stuff, when we're creating programs and interventions, you know, really holding that parity of esteem, you know, for employees and employed people and self-employed people, I think is really critical, because there's self-employed people with disabilities out there that just are getting far more stressed because they don't have a safety net of an employer.
Thanks, Helen. There's a couple of people want to come in before we finish, but great, always good to have your contributions. John, go ahead.
It's me, Pippa, actually. I just wanted to kind of round up really by thinking about, you know, we're talking about people in their whole lives here. Yes, this webinar is about employability, but what we know from the centre here is that people come in with one reason, and yet there are many, many others around that make their lives better. So we can't just think of that in isolation. I think the support for family, the support for mental health is definitely a big factor, and support for any other aspects of their life. In our case, we have a gym which helps with their physical activity and therefore their well-being. You know, we need to look at the person in the round and not only their employability and their employment situation.
Brilliant. Thanks very much, Pippa. And there's been a great vote of confidence in the Brain charity in the chat as well. It's entirely appropriate that Ruth will round us up in a minute. But just before we go there, thanks, Julie, very much for posting your story in the chat. Really interesting to hear that and see how there has been service responses. Emma and Ellie, anything finally you want to say? You don't have to, but anything before we close? Fine.
Nothing from me. Thank you, everyone.
Great.
No,
Ruth, would you like to?
Part of it.
Great, thanks, Emma. Ruth, would you like to have final word?
Yeah, I've just found this really, really interesting, and particularly the collaboration, even in the chat, and people wanting to work with each other, which shows what an important area this is to develop. And I totally agree with Pippa. It's about the whole person and then enabling them to look at what they want to do with their life. And I think Julie's story really indicates that. I'm looking forward to working with people in the working group, was the last thing I wanted to say, because the MS Society is prioritising work on employment and disability, and we have run a survey, and I hope to be able to share the findings of that from people who are experiencing hopefully some positive but also a lot of very difficult circumstances in employment. So it would be great to be able to share that with people here in the chat and have a conversation about how to move that work forward. Thanks, Alan.
Excellent. Thank you very much, Ruth, and thank you, Ruth, for being the instigator of this whole webinar. Thank you very much to all the speakers. Those were excellent presentations. We'll make the webinar available as a recording afterwards. We'll make the slides available as well. And Alison, I'm going to have to ask you to answer that question about whether we can make the chat available. Thank you very much, everybody. Thank you, everybody, for the questions and for generally participating. Excellent webinar. We'll be running another one again, maybe at the end of December, maybe it'll be the end of January. But great to see everybody here, and thank you for joining us today. Bye.
Thank you, Alan. Thank you, everyone.
Thanks. Bye.
Bye.